This is another T2 weighted image. Why I am telling T2? The fluid is bright here. So this is another T2 weighted image. What you are seeing here is multiple small round lesions with central dot seen in the central dot is represents the scolex of the lesion, scolex of the cysticercus larva. Okay, that is the scolex. So there will be multiple lesions in varying stages of development. That is the classical imaging feature of neurocysticercosis, and you will get a classical image like this. It has been asked many times. Okay, so once there was a question. In that question, they asked in which stage of neurocysticercosis the patient will be more symptomatic and presenting with severe symptoms. Okay, so you have to understand the developmental stages of neurocysticercosis. There are 4 stages in neurocysticercosis, which is classified as Escobar classification staging. So, in the first stage, that is the vesicular stage. See, the larva, there will be a cystic lesion with a tiny central larva and scolex will be seen. That is known as the vesicular stage. And after this stage, the larva will develop. And what happens is, because of the immune reactions, the larva may start getting died. Okay, they will start dying. So in that stage, what happens is there will be intense inflammation going on. Because of this intense inflammation, there will be white matter edema. See, the lesion has become increased in size, and this surrounding white region shows the edema. So the patient will be much symptomatic in the second stage, that is in the colloidal vesicular stage. So remember this. This was asked once. Okay, the patient will be much symptomatic in the colloidal vesicular stage. After that, what happens is either we start the treatment or because of the natural immune response, the healing will start and the edema will comes down. That is the third stage known as the granular nodular stage. And finally, the lesions will get calcified like this. Okay, that is known as the nodular calcified stage, which is the healed stage. So in neurocysticercosis, you have to remember there are 4 stages. One is the vesicular stage in which you will be able to see. So here, this is a vesicular stage. You are not seeing much edema. You are seeing multiple cysts with the scolex. So that is a vesicular stage. Then in colloidal vesicular stage, because of the immunity, what happens is there will be the larva will be dying. There will be intense inflammation. The patient will be much symptomatic. Then because of immunity or because of treatment, what happens is healing will start. That stage is known as the granular nodular stage. And finally, all these lesions will get calcified. That is known as nodular calcified stage. So remember all the 4 stages of neurocysticercosis. Okay, and so this is how questions can come. Clinical radiology questions can come from neurocysticercosis. Now coming to another, sometimes they can give you an image like this, and they can ask you to identify the investigation. So how to tell the name of investigation here. So here you are seeing what first of all you should see the normal anatomy. Here you are seeing bowel loops. So you should understand whether it is small bowel loops or large bowel loops. So these are the small bowel loops. Why I am telling these are small bowel loops is because of the presence of valvulae conjunctis. Presence of valvulae conjunctis. See, all these are these linear lines seen throughout the bowel loops. This is called as the valvulae conjunctis. So this is a case of enteroclysis. So what is enteroclysis? This is one question. Okay, enteroclysis is also known as the small bowel enema or something. Okay, what we do in enteroclysis is we will insert a tube known as the Bilbo daughter tube. So there's a tube known as the Bilbo daughter tube. This tube is inserted up to the gastroduodenum, after just beyond the pylorus of the stomach, and we will inject the contrast. Okay, we will give the contrast. Either we can give a single contrast agent or double contrast, or we can give contrast plus medial cellulose. Okay, whatever it is, we will give the contrast, and we will distend the small bowel loops. So enteroclysis is an investigation to study the small bowel loops. Okay, so these are multiple jejunal loops showing valvulae conjunctis. So valvulae conjunctis can be seen both in jejunal loops and ileal loops. So this is a question relating anatomy. Okay, so if you want to study a pathology of small bowel loops, either ileum or jejunum or proximal duodenum, ileum or jejunum, you can do this enteroclysis. Okay, so how to do an enteroclysis? First of all, we have to put up the tube, that is known as the Bilbo daughter tube. Then we have to inject the contrast through the tube, then take X-ray. So this is how you will take enterography. This is how you do enteroclysis. Okay, this is how you do the enteroclysis. This is how you do the enteroclysis. Okay, 1 second. So enteroclysis is for studying the small bowel lobes. So enteroclysis is for studying the small bowel loop. So how to evaluate all other parts of bowel loop? So there are different investigations for all this. If you want to study the upper digestive tract, that is esophagus and proximal part of stomach, we can do a barium swallow. Okay, we can do a barium swallow. So how to do a barium swallow? We will give barium sulfate. Okay, for all this investigation, the agent given is barium sulfate. This was previous question. Okay, barium sulfate. This is a non-toxic agent. This is non-toxic. It is non-absorbable. That is why we are giving barium sulfate. It is non-toxic. It is non-absorbable, easily excreted. So all these are the good properties of barium sulfate. So you can easily give barium sulfate and take X-rays. So you can evaluate proximal pharynx, esophagus, proximal stomach by using barium swallow. Then for barium meal, by doing barium meal, you can evaluate stomach and duodenum. And barium meal follow through or enteroclysis can be used for small bowel, and barium enema for large bowel loops and rectum. Okay, so these are the barium investigation. These are the contrast investigations that are used for evaluating each part of bowel. Okay, I hope it is clear. Now coming to another question. So this is another classical spotter. So if usually in this will be a question related to surgery, and they will be giving you a history of a male child, usually a firstborn male child who presented with abdominal pain or vomiting immediately after birth or 2 to 8 weeks after the birth. So from the history itself, you will be able to make the diagnosis of congenital hypertrophic pyloric stenosis. So how to make the diagnosis? Okay, that is the question. So if you are given an image like this is a part of liver. Just ignore that. So this is the stomach. And what you're seeing here is the pylorus. So in congenital hypertrophic pyloric stenosis, there will be hypertrophy of the pylorus. Okay, the pylorus will be elongated like this, and it will be thickened like this. Okay, so this happens. It will be more than 16 mm in length, and it will be more than 4 mm in thickness. So this is the criteria. This is the ultrasound criteria for diagnosing congenital hypertrophic pyloric stenosis. It should be 16 mm elongated, and it should be at least 4 mm thick. So if you see a image like this, it resembles the cervix of a female. Okay, in ultrasound, cervix will be also seen like this, but this is a stomach. Because of the thickening of this pylorus, we are seeing like this. Otherwise it will be the uterus, or it will be the cervix, and here vagina. That is how it is seen in a female. Okay, so since it mimics the cervix, this is known as the cervix sign. Okay, this is known as the cervix sign. And what happens here is, since this antrum is projecting out like a nipple, this is known as the antral nipple signs. Okay, this is the antral nipple sign. All these signs, all these many questions has been asked regarding congenital hypertrophic pyloric stenosis. This is very important. If they are giving you an image of the cervix sign or antral nipple sign, then you should be able to diagnose this. So this is a long axis image, and if you are seeing it in the short axis, if you are seeing it in an axial section in a short axis, it will seem like this. This is called as the target sign. So this is another named sign in congenital hypertrophic pyloric stenosis. So in ultrasound, three named signs are there for CHPS. That is the cervix sign, the antral nipple sign, and the target sign in axial section. Okay. Why I am telling this is, don't confuse it with the fluoroscopic sign. So what happens in fluoroscopy is, it will be barium meal. We will do the barium meal. We will give contrast to the baby, and we will take series of X-rays. Okay, and there are a number of signs, named signs, in congenital hypertrophic pyloric stenosis. What happens is, because of this stenosis, what happens is there will be a delay in gastric emptying. That is the first and foremost thing that is going to happen. Okay, because of this stenosis, there will be delay in emptying. So what does the stomach do is, it will try to empty. So there will be multiple peristaltic waves, which will be seen as a caterpillar. Okay, so it is known as the caterpillar sign. There will be multiple peristaltic waves. That is the that is another named sign. and the pylorus will be elongated. You will be able to see a narrow stream of mucosa. So a narrow stream of contrast will be passing. That is known as the string sign, and the thickened puckered mucosa will be seen as double track sign. So there, you don't need to understand in depth about all these signs, but just remember whenever you are seeing about caterpillar sign, string sign, or shoulder sign, or mushroom sign, all these signs are seen in congenital hypertrophic pyloric stenosis. So the presentation of the baby will be usually it will be a male child, the male child presenting with acute onset of vomiting, and there will be dyselectrolemia. Okay, because of repeated vomiting, there will be dyselectrolemia, and the UST criteria is the pylorus should be thickened more than 4 mm, and it should be elongated more than 16 mm. So remember this. These questions has been asked. Okay. So coming to the imaging of liver, this is a very commonly asked, which is a very commonly asked question in the NEET exams. You should know how all the liver lesions will be appearing. So that is very important. Okay. So first of all, we will see the most common lesion, the most common benign lesion of liver, that is hemangioma. So how hemangioma is appearing? So whenever you are seeing an OP, whenever a patient comes to you with abdomen pain, and you will be sending the patient for ultrasound, and if the ultrasound picks up some liver lesion, the next investigation that you should do is a triple phase CT. Okay, that is the basic. You should do a triple phase CT. So this was previous questions. What is the investigation of choice for liver lesions? Olden days, they used to ask their radiology questions directly like this. Nowadays, the questions will be clinical radiological. They won't ask like that. They will ask it in a more complex way. So you should know the basics. So you should ask for a triple phase CT. So what is a triple phase CT? That is the first thing that you should understand. First what we do is we will obtain a plain CT image. Okay. First, I will take a plain CT. Then we will give contrast, IV contrast to the patient. So what is the contrast agent used? Okay, that you should know. Iohexol is the most commonly used contrast agent. Most commonly used agent is iohexol. All are iodinated contrast agents. In MRI, we were using gadolinium-based contrast agents. That is a question that can come. MRI uses gadolinium-based contrast, whereas CT uses iodine-based contrast agents. The most commonly used contrast agent is iohexol. So then what I will do is I will inject iohexol through the veins of the patient, and I will obtain 3 series of images. That is why it is known as triple phase CT. The first phase is known as the arterial phase. The first phase is known as the arterial phase. So after injecting the contrast, if I take an image by 25 to 30 seconds, I will be getting an arterial phase image. Okay. Then I will obtain a venous phase image. Okay. Venous phase image by 45 to 60 seconds. Okay. And after 2 to 3 minutes, I will get a delayed image. So after injecting the contrast, I will obtain 3 sets of image. One arterial phase, another is the venous phase, and other is the delayed phase. So this is how a triple phase CT is done. Okay. So this triple phase imaging will help you to the triple phase imaging will help you to characterize a liver lesion. So that is the concept. So first and foremost thing that you should study is about the hemangioma. Why hemangioma is important? Because it is the most commonly seen liver lesion. Otherwise, it is a very benign lesion. It is causing no problem to the patient. Usually, it will be asymptomatic in adults. In children, they can cause symptoms like if there is a giant hemangioma causing there is a reduced thrombocytopenia, that is known as the Kasab-Merrick syndrome. Okay, so that those rare complications can come, but usually hemangioma is a very benign lesion. So if you are getting hemangioma, then you should be happy. The patient should be happy because that is a touch me not lesion. You don't need to do anything for hemangioma usually. Okay, so you should understand how an hemangioma is seen in CT. So this is how it is characteristically seen in CT. So this is the arterial phase. Why I am telling this as arterial phase is because see, aorta is getting the contrast. Aorta is filled with contrast. So mostly this is an arterial phase. The contrast is passing through the artery. That is why it is known as the arterial phase. So in hemangioma, what happens in arterial phase is there will be peripheral, non-continuous, discrete enhancement focuses seen like this. See, peripheral nodular discrete enhancement seen like this. Okay, so if you are seeing peripheral nodular discontinuous enhancement in the arterial phase, then you should think in terms of hemangioma. What happens in next phase is the filling will increase into the center. Okay, in portal venous, in the venous phase, the filling will increase like this, and in delayed image, there will be complete filling in. Okay, there will be complete filling in delayed phase. So this is how you will get an hemangioma. So in arterial phase, there will be peripheral discontinuous enhancement. Then slowly it will fill in, and finally there will be complete filling in. Okay, that is the classical appearance of hemangioma. I will tell you why. Because here the central part of the hemangioma will be fibrous tissue. This fibrous tissue is a very lazy cell. Uh, these cells will take up the contrast only at the last. Okay, they will take up the contrast only at the end. So that is why by the end, there will be complete contrast filling in the center of the lesion. So this is the classical appearance of hemangioma, which is the most common benign liver lesion. And in MRI, this is an MRI image. If you are taking a T2-weighted image, you will get a sign known as light bulb sign. This light bulb sign can be seen at many occasions. If in X-ray shoulder, in posterior dislocation of X-ray shoulder, you can get a light bulb sign. Other in pheochromocytoma adrenal, the pheochromocytoma will be very brightly seen just like this. You will get a light bulb sign. Also in hemangioma, you will get a light bulb sign. Okay, so coming to the points of hemangioma, it is the most common benign liver lesion. It is very common in female. Usually it is asymptomatic, so you don't need to do anything for hemangioma. But if it is symptomatic, then only management is required. Usually it is symptomatic. Sometimes hereditary association can be seen in cases of Osler-Weber-Rindau syndrome. There will be multiple hemangiomas here and there in the body. And in Kasama-Rizk syndrome, what happens is there will be the hemangioma will be more than 5 centimeter. Hemangiomas more than 5 centimeter is known as giant hemangioma. Okay, if it is more than 5 centimeter in size, that is known as giant hemangioma. These hemangiomas can take in these blood cells like platelets, resulting in thrombocytopenia. That is known as Kasama-Rizk syndrome. You all know this. For investigation, you can do ultrasound. Ultrasound will show a liver lesion. Usually, it will be bright liver lesion. So if you do CT, you have to do a triple phase CT, and that triple phase CT will be showing peripheral nodular discontinuous enhancement with the gradual central filling in. I hope this is clear. It is very important. That is why I am taking more time. Coming to the second liver lesion, the other important liver lesion, that is hepatic adenoma. Why adenoma is important? Usually in olden days, the questions were asked like this. A patient, a female, a 40-year-old female who was on OCT came to you. She came with a severe abdominal pain. On exam, when you did an ultrasound of pelvis, there was a liver ultrasound of abdomen and pelvis. There was a liver lesion. There was hemoperitoneum. So you suspected the rupture of the lesion, which could be the lesion. So the thing is, hepatic adenoma is a lesion that is very prone for rupture. Okay, hepatic adenoma is a lesion that is very prone for rupture. It is commonly seen in women taking OCT. So in CT, you will be able to see a discrete, whenever there is a rupture, the lesion will be seen discrete like this, and inside the lesion there will be areas of hemorrhages can be seen. Okay, hemorrhage will be appearing bright, acute hemorrhage will be seen bright in CT, so you will be able to see the areas of hemorrhage within this. Okay, so you will be able to see areas of hemorrhage within this. The hemorrhage will be seen bright like that. Okay, so that is the importance of hepatic adenoma. But recently in one of the competitive exam, they asked about the types of hepatic adenoma. Okay, they asked about the types of hepatic adenoma. So according to a classification known as Bordeaux classification, there are 4 types. Okay, there are 4 types of hepatic adenoma. The most common type is known as the inflammatory hepatic adenoma. Another important type, which can be seen with multiple lesions, that is known as the HNF1 alpha. And the third one, which is very rare, but which is very common for malignant transformation, that is known as the beta catenin type. All these are related to the mutation of hepatic adenoma. So third one is beta catenin, and the fourth one is unclassified. So just remember 3 things. Inflammatory is the most common. HNF1 alpha is usually seen as multiple adenomas. So whenever there is multiple adenomas, if they ask which can be the type, then you can tell it is HNF1 alpha type. And the third one is beta catenin type. It is usually seen in men, okay, who are taking anabolic steroids. If a history like that comes, there is a liver lesion in a male patient who is routinely doing gym work with intake of anabolic steroids, which can be that, then the answer can be beta catenin type of hepatic adenoma. Okay, so these are the important points regarding hepatic adenoma. I hope that is clear. So in imaging, you will be able to see hemorrhage within the lesion. So there will be hemoperitoneum because these lesions are very prone for rupture. That is the cause. Now coming to the most important one, that is hepatocellular carcinoma. You should be knowing this thoroughly because nowadays we are giving LiRADS, just like BiRADS, there is LiRADS for liver imaging analysis and data system. So that is LiRADS. So in what happens is we have to say, as I told you, we have to obtain an arterial phase image. I have explained everything before, a portal venous image and a delayed image. What happens in HCC is hepatocellular carcinoma is there will be APHE. What is APHE? Arterial phase hyper enhancement. There will be arterial phase hyper enhancement. So you should understand why there is hyper enhancement in arterial phase. Normally liver, 80% of the liver is supplied normally by portal vein. But whenever there is a hepatocellular carcinoma, that hepatocellular carcinoma is supplied by the hepatic artery. So see, this is arterial phase. So what happens is there will be hyper enhancement of the lesion. The lesion will enhance brightly in the arterial phase because it is supplied by the hepatic artery. That is the reason, nothing else. Okay. See, you are able to see multiple arterial feeders supplying the lesion in the arterial phase. That means the lesion is supplied by the hepatic artery. So there is arterial phase hyper enhancement. And then what happens is the portal vein will take this contrast away and there will be sudden washout in the portal vein phase. Okay. See, if you see here, this lesion is bright comparing to the liver parenchyma. But in the second phase, this liver parenchyma lesion looks almost similar. And in delayed phase of imaging, there will be complete washout. And the lesion will be seen black and the other part of the liver will be seen bright. So if there is arterial phase hyper enhancement with rapid washout, that is classical for hepatocellular carcinoma. So according to the recent guidelines, if the imaging appearance is classical, that is if the lesion is showing arterial phase hyper enhancement with rapid washout, and if the alpha fetoprotein levels is elevated, then there is no need for doing the biopsy. Otherwise, usually what we will do, we will ask the patient to get a biopsy done. We will check that we will do the histopathology examination. We will confirm the diagnosis. But recently, if the imaging appearances is classical, that is, if there is arterial phase hyperenhancement with washout in these daily images, and if the alpha fetoprotein of the patient is raised, then no need for biopsy. This is the recent guidelines. This is what the recent guidelines tell. Okay. Another important marker that can be elevated in HCC is PVCA2. Okay, just remember this. PVCA2 is another important marker that can be elevated in HCC. So moving forward, another very important spotter, that is the fibrolammellar cell carcinoma. You know why this is important, because always question will ask you to differentiate between this fibrolammellar carcinoma and focal nodular hyperplasia. I will help you to sort out how to differentiate these things. Okay. So fibrolammellar variant of hepatocellular carcinoma is a malignant lesion, which is common in 20 to 40 years of age. So this is a lesion that should be treated. Okay. So here, what is the classical appearance is the patient will be having a central stellate scar. The lesion will be having a central scar. There will be a central scar. And if you do a CT, there will be calcification seen within the central scar. So the presence of calcification help you to differentiate between fibrolammellar carcinoma and focal nodular hyperplasia in CT. So there are other features I will tell you. Consider this as FLC and this one as FNH, focal nodular hyperplasia. So first the CT, calcification is seen in 65%, very less incidence in focal nodular hyperplasia. Then if you do an MRI, the scar will be hypo in T2-weighted images in fibrolammellar carcinoma, whereas the scar will be bright. The central stellate scar will be bright in focal nodular hyperplasia. So you have to understand that focal nodular hyperplasia is not a malignant lesion. This is just a hamartoma. Okay. So the central scar will be bright. The prognosis of the patient is also bright. So you can remember like that. One sophisticated investigation is there, that is technetium 99 sulfur colloid scan. Here, the central scar is made up of fibrosis. The central scar is fibrous only, fibrotic band only. So no uptake. But here this is an hamartoma with the living cells. It will show uptake. Sulfur colloid uptake plus. So I have taught you one CT point, one MRI point, and one nuclear medicine point to differentiate between focal nodular hyperplasia and fibrolamellar carcinoma. Remember, fibrolamellar carcinoma is a malignant lesion. It is very, very important to make the diagnosis because FNH is a benign condition. It is a hamartoma, no need to treat, but fibrolamellar carcinoma is a malignant condition. You need to act very fast. So you have to make the diagnosis. So first you can take a CT, and if there is a calcification in the central scar, it is more likely to be fibrolamellar carcinoma. And if I am suggesting you MRI, you are sending the patient for MRI. If in T2-weighted image, if the central scar is bright, that can be focal nodular hyperplasia, and if it is dark, it can be fibrolamellar carcinoma. So we are so if you want to confirm, then you can do a sulfur colloid scan. Since the cells in the scar are living, it is usually reticuloendothelial cells. Okay, REC is seen within the scars in FNH, so it will take the sulfur colloid. The reticuloendothelial cells, the Kupffer cells, the reticulum, that is the Kupffer cells, is seen in FNH. I told you it is a hamartoma, so that it will be Kupffer cells will be seen. So it will take up the sulfur colloid. But since it is just a fibrotic tissue here, fibrolamellar cell carcinoma will not take up any sulfur colloid. And one marker that help you to make the diagnosis is neurotensin. Neurotensin level will be elevated in FLC. This is another serum marker that will help you to make the diagnosis. I hope I have made it clear. Okay, these are the 4 important differentiating points that you can make out, and you can make the diagnosis. Okay, now coming to CT in finding out ischemic stroke. So whenever a patient come to you with a sudden onset of upper limb or lower limb weakness or numbness, something like that, whenever you want to rule out a stroke, the first and foremost investigation that you will do is a CT brain. Okay, the first and foremost investigation that you will do is a CT brain. It will help you to rule out hemorrhage. So the most important role is it will help you to differentiate whether it is a ischemic stroke or a hemorrhagic stroke. Because if you're seeing the hemorrhage, then you can't send the patient for thrombolysis. That is the concept. Okay, so you can't send the patient for thrombolysis because it is already bleeding there. Okay, so the CT will be very readily available, easily available everywhere. So CT will be the best investigation, that the first investigation that you will get. Then if there is no hemorrhage, then you have to do MRI, preferably DWA sequence first. I told you diffusion weighted imaging is a sequence that will help you to identify infarct. So in CT, a infarct will be seen like this. Okay, this is how a infarct can be seen in CT. So it will be seen as hypodense area. It is seen as hypodense area, just like this. Okay, it is seen as a hypodense area like this. Okay, so I hope it is clear. So whenever you are in doubt, what you can do is you can, because CT will miss many of the infarcts. So whenever there is doubt, you can go for MRI and DWA. So the importance is there are some signs that will help you to make the diagnosis. Sometimes the infarct won't be evident like this. So there are some salient signs. The first one is dense MCS sign. Okay, so dense MCS sign is seen in acute infarct because of the clot or thrombus. MCA will be bright. That is a simple logic. Okay, that is known as the dense MCA sign. Okay. Then another important sign is the disappearing basal ganglia sign. Disappearing basal ganglia sign. What happens is here, if you see, the basal ganglia will be normally seen on both sides. This is the head of caudate. This will be the region of putamen. If there is an infarct like this, the basal ganglia will be disappeared. Okay, that is known as the disappearing basal ganglia sign. And third one is the obscuration of insular ribbon. Okay, so the third one is the obscuration of insular ribbon. So these are 3 signs that will help you to find out the infarct in CT if it is very early phase. Okay, because after 4 to 5 hours, we will be able to see the infarct like this. But even before that, if there's a dense MCA sign or disappearing basal ganglia sign, or if there's obscuration of the insular ribbon, you should think in terms of an acute infarct and you should get a MRI with a DWA very fast. Okay, so that is the concept. So why I am telling about stroke here is because 2 years back, I guess they asked about this aspect score. Okay, aspect score. Aspect score is nothing. It is the Alberta Stroke Program Early CT score. Okay, so this is a scoring system that will help you to predict the prognosis of the patient. So it will help you to predict the prognosis. So what they are doing here is, see the image. So this is usually done for MCA territory infarct. So this is done for MCA territory infarct. What they usually do is they will give 1 point for 10 regions in brain which is supplied by MCA. They will give 1 point each for 10 regions supplied by MCA. So 1 point for head of caudate, 1 point for lentiform nucleus, 1 point for internal capsule, 1 point for insular cortex. This small part between the lentiform nucleus and the cortex is known as the insular cortex. Then 1 portion for the cerebral this M1, M2, M3, M4, M5, M6 regions. Okay, so they will give 1 points each for all these regions. And out of 10, if there is infarct in 3 regions, see there is infarct in the insular cortex here. There is an infarct involving some part of lentiform nucleus. Here, this right side lentiform nucleus is normal, but left some part of lentiform nucleus is affected. And if there is infarct in the M1 region, so 3 regions are affected. So what we will do is we will minus this 3 from this, and we will get a score of 7. So this is how we will obtain aspect score. So whenever the score is equal to or less than 7, the patient will be having poor prognosis, and if you do thrombolysis, there is a high chance for hemorrhage. So this is the importance of aspect score, that is Alberta Stroke Program Early CT score. So it is a score that is given for MCA territory infarct. Okay, usually we will go for MCA territory infarct. We will give 1 point for 10 regions: caudate nucleus, lentiform nucleus, internal capsule, and insular ribbon. Then 6 regions of cortex: M1, M2, M3, M4, M5, M6. You should see this image. And what we will do is we will subtract 1 point from each region affected. And if the score is less than or equal to 7, then the patient prognosis will be poor. So that is the take home point. So now we should understand the territories. Okay. So what happens is MCA will be supplying. So this is the intrahemispheric fissure. MCA will be supplying the lateral portion of the brain like this. Okay, the lateral portion of the brain. That is what we have shown. See, this is the territory of MCA. Mainly the gangliocapsular region and the peripheral part of the brain. Always remember, the central area of the brain is supplied by anterior. The medial part of the brain is usually supplied by the anterior cerebral artery. The central area of the brain is usually supplied by the ACA. This region is supplied by the ACA, and the peripheral region is supplied by the MCA. And we all know posteriorly the supply is for posterior circulation, that is posterior cerebral artery and its branches. So if you see the midline section, see this is the midbrain, pons, medulla, the midline section. That part you have to understand, the ACA will be coming like this. It will be arching over the corpus callosum, sending the branches like this. So anterior cerebral artery will be supplying the medial half, and MCA will be supplying the lateral half. So that is this is a very important region of the brain. This is the this is the Broca's area. This is the Wernicke's area. Okay, this is the inferior frontal gyrus and superior temporal gyrus. Inferior frontal gyrus will be the Broca's area. Superior temporal gyrus will be the Wernicke's area. So all these are supplied by the middle cerebral artery, and posteriorly it is supplied by the PCA. Okay, that is the importance. So this image is very important because this has been asked multiple times in various entrance exams, especially in NEET exam. Okay. Now moving forward. Now you should understand the T1 hyperintense lesion. Usually, almost all the pathologies will be usually it's not normal. Usually the pathologies will be hyperintense in T2 and hypointense in T1. That is bright in T2 and black in T1. That is the case of around 90% of lesions. But there are some lesions that will be showing bright, that is hyper, that will be appearing bright or hyper in T1 weight images. You should know because this has been asked a n number of times. First one is slow flow. Okay, slow flow. See, this is a case of CVT. There is a clot in the superior sagittal sinus. So there is a clot in the superior sagittal sinus. So slow flow or clot can be seen as bright in T1 weight image. Then another one is lipoma. Any lesion containing fat, will be bright. Fat will be bright in T1 weight images. Another is subacute stage of hemorrhage. Okay, not all stages of hemorrhage, but subacute stage of hemorrhage. Okay, subacute stage of hemorrhage. So if you make any, there are two F's, that is fat flow, that is slow. Then 3M will come. M. One is melanin. Whenever there is a metastasis in the brain from melanoma, it will be bright. Melanin will be bright. Methemoglobin will be bright. Methemoglobin. That is why subacute hemorrhage. Subacute hemorrhage will be having methemoglobin in them. So that is why it is bright. Then any minerals like magnesium or gadolinium, that is why contrast is bright. Okay, that is why we give contrast. So just remember 2F, 3M, fat, slow flow, melanin, and hemoglobin, minerals like magnesium, then gadolinium, etc. All this will be bright in T1 weight images. This is another important question that usually asked in entrance. Okay. Now moving forward to some gynecological parts. So usually the question will be here in the case of ovarian torsion image I am giving. So usually the question will be patient will be presenting to the OP with severe lower abdominal pain, usually presenting to one side. Okay, either right lower abdominal pain or left lower abdominal pain. You will immediately send the patient for ultrasound. And what the ultrasound will show is unilateral enlarged ovary. See, the ovary will be enlarged unilaterally. The contralateral side will be normal, and the follicles will be peripherally arranged like this. See, the follicles are peripherally arranged. So if you are seeing unilateral enlarged ovary with peripherally arranged follicles, okay, then that is classical for ovarian torsion. So that is how you will make the diagnosis of ovarian torsion. Why I am stressing the word unilateral means if the ovaries are bilaterally enlarged and if the patient is presenting to you sick, then you should ask the history of any infertility treatment, because in ovarian hyperstimulation syndrome, one question was once asked in 2018 or 19, I guess. In question there was bilateral enlarged ovaries with the peripherally arranged follicles. Okay, so if bilaterally affected, then you should think in terms of ovarian hyperstimulation syndrome. But if it is unilaterally affected, then that it is usually mostly because of torsion. And you will be able, whenever you're doing a color Doppler, you will be seeing whirlpool sign. Okay, you will be seeing whirlpool sign. And this whirlpool are this sign, if you are not seeing color Doppler, it will be having a, because everything is twisting like this, so we will be having a target appearance. So that is the concept. So whenever there is a unilateral enlarged ovary with the whirlpool sign present, then torsion ovary will be the diagnosis. Okay. Another important spotter that can come from this gynecological part will be regarding ectopic pregnancy. There are multiple signs, because what happens in ectopic pregnancy is, imagine this as the uterus, this is endometrial cavity, the fallopian tube, ovary. Usually, implantation should take place within the endometrial cavity. Okay, that will be the normal position of implantation. But in ectopic pregnancy, what happens is there will be implantation outside the endometrial cavity. It can be in the myometrium, it can be in the ovary, it can be in the fallopian tube, which is the most common side. So, what happens is the blood vessels will be reaching here will be having less amount of muscle. If the implantation is occurring within the endometrium, the blood vessels reaching here will be how to penetrate much more muscular myometrium. So it will be having high resistance. But what happens here is, since it is reaching a region with less musculature, because fallopian tube is not having that musculature as compared to ovary, so there will be low resistance flow. So there will be high low resistance flow like this. That is known as the leash sign. There are many signs, okay, that is known as the leash sign. And we will be able to see a blob of tissue outside a mass of tissue outside, separate from the uterus and endometrium. That is known as the blob sign. So there are many signs. You must be familiar with the ring of fire sign, but apart from that, I have to tell you there are multiple signs known as leach sign. Because of the low resistance flow, that there will be intense flow like this, that is known as the leach sign. You will be able to see a blob of tissue apart from the uterus or ovaries, that is the blob sign. And inside that, sometimes inside the tissue, you may be able to see a yolk sac, that is known as the tubal ring sign. See, inside the blob, you are seeing a yolk sac, that is known as the tubal ring sign. Sometimes cardiac activity can be seen inside that, that is known as vagal sign. So there are different names, and you can see this slide again, and remember there are multiple named signs apart from the ring of fire sign in ectopic pregnancy. So transvaginal ultrasound is the investigation of choice for finding out an ectopic pregnancy. It will easily find out the ectopic pregnancy and site. Okay, so I hope we can move forward. Now coming to some normal anatomy. This is a case of a traumatic knee which was taken. So here there is a injury to the anterior cruciate ligament. Okay, so this is the anterior cruciate ligament. I just want to tell you. So in a sagittal section, anterior cruciate ligament will be going like this from the anterior aspect of the tibia. It will be growing and inserting into the medial portion of lateral condyle in female. That is the normal anatomy. It will be going and inserting into the medial portion of the lateral femoral condyle. Okay, ACL will be getting attached to the medial portion of the lateral femoral condyle here. So its orientation is like this, and PCL is usually running from the posterior aspect of tibia and attaching into the lateral portion of medial femoral condyle opposite to this, and it will be having a C shape, a reverse C shape like this. Okay, so in image, if they ask you to identify ACL and PCL, ACL will be seen like this and PCL will be seen in a reverse C like fashion. Okay, and meniscus a meniscus will be seen like this. This is one meniscus here. This is the medial meniscus here. This is the lateral meniscus here. So this is how meniscus will be seen in MRI. Okay, just for your understanding, I have put this. Okay. Now moving forward to another musculoskeletal related, orthopedics related questions. This is a case of Perthes disease. Okay, this is a case of Perthes disease. So, what is Perthes disease? This is a idiopathic avascular necrosis of femoral head. Idiopathic avascular necrosis of femoral head. So the best sequence that so it can be seen in X-ray and MRI. So X-ray and MRI are the investigations that are usually done. X-ray will be the first investigation. MRI will be the second investigation, because MRI can show much more things which can be missed in MRI. So which can be missed in X-ray. So what happens is here is, okay, we why the orthopedician is sending a patient with AVN or Perthes disease to a radiologist is, it is usually to stage the disease, because they can plan whether they have to go for a decompression or whether they have to do a hip replacement. So it will all depends upon the stage and clinical condition of the patient. So we have to stage the disease, and staging is usually done according to Fickett and Orlet classification. I will tell you what is Fickett and Orlet classification. See, this is the normal femoral head. So this is the right side, this is the left side, this is the normal femoral head. What happens here is, in this T1 weighted image, this is a T1 weighted image. What happens is, see, there is a geographic area of hypo blackening is seen here. Okay, there is a geographic area of blackening seen here. So, okay, so that is seen. Wait a second. Okay, so that is it. Okay, so that is the region of avascular necrosis. This is the region of avascular necrosis. So we can stage the disease. So there are 4 stages: stage 1, stage 2, stage 3, and stage 4. You should remember, in stage 1, X-ray will show no finding. There will be no finding in X-ray. X-ray will be usually normal. But in MRI, there will be marrow edema seen. There will be marrow edema seen. So MRI will help you to pick up avascular necrosis at an earlier stage. It will show the marrow edema. Okay. In X-ray in second phase, there will be areas of sclerosis and osteopenia. There will be areas of sclerosis and osteopenia. While in MRI, there will be a geographic T1 hypo region. which I have showed you, that there will be a geographic area of T1 hypointensity seen like that. And in third stage, both will show one sign known as the crescent sign. Okay, both will show crescent sign. Here also crescent sign will show. And stage 4, there will be degenerative osteoarthritis. So in first stage, the X-ray will be normal, but there will be edema in MRI. In second stage, there will be areas of sclerosis and osteopenia in X-ray, while there will be area of geographic defect in MRI. And in stage 3, there will be crescent sign positive. What is crescent sign? Imagine this as the femoral head. So there will be a crescent of collapse. So this is how the collapse starts. There will be a crescent of collapse involving the femoral head. That is known as the crescent sign. That can be picked up in both X-ray and MRI. And in stage 4, what happens is there will be multiple subchondral cyst, erosion, degenerative osteophytes. That is, the osteoarthritis will set in. So that is the importance of Fickett and Orler classification. So whenever a child comes to you with limbing, many things you have to rule out. The most common thing that you have to rule out is the Perthes disease. You have to take an X-ray. You have to see whether there is any changes of vascular necrosis going on there. If you are having some doubt, then you have to do an MRI and rule out AVN, that is the Perthes disease. Okay, Leclerc's Perthes disease. Now coming to another cause for this limping and pain in pediatric age group, that is slippery capitofemoral epiphysis. This is also a very repeatedly asked question. Okay, so this is slippery capitofemoral epiphysis. This is usually seen in obese male adolescent child. Adolescent, okay, people. So the history will be a obese 13-year-old male, obese, came with limbing pain in one side, or sometimes both sides. That can be the history. So first thing you have to do is you have to go for a X-ray. Okay, X-ray AP view, and also you can take X-ray AP view and frog leg view. These are the views that help you to make a diagnosis of slipped upper femoral epiphysis or slipped capitofemoral epiphysis. Then after taking X-ray, what you have to do is you have to draw a line like this. Okay, you have to draw a line like this. This line is known as the Kleene line. Okay, this line is known as the Kleene line. This Kleene line, see, this should intersect some portion of femoral head like this. That is normal. If the Kleene line is intersecting some portion of the femoral head, that is normal. But if it is not intersecting, just like here you see the femoral head is slipped. There is no intersection at all. The head here has been slipped down. Okay, so that is known as the Truthoven sign. All these are very important because this has been asked multiple times. Okay, so this is the Truthoven sign. Another important one sign is there, that is known as the metaphyseal Blanche sign. The metaphyses will be appearing more sclerotic, or involving high. There will be high X-ray density in metaphyses. That is known as metaphyseal Blanche sign. So this is how you should make a diagnosis of slipped capitofemoral epiphysis. Okay, this is because the head will be slipped and it will not intersect the Kleene line. Okay, that is the concept. I hope that is clear. Now we can move forward to another spotter. So if you see this X-ray, I will tell you how to approach an X-ray. First of all, if you are given an X-ray, first you have to see is the easy way to interpret an X-ray is A, B, C, D. Okay, A, look for the airway. See the trachea, whether it is in the midline. Then look for the bones. Okay, then look the costophrenic and cardiophrenic angles, and then look the diaphragm. So this is the costophrenic angle, cardiophrenic angle. This is the costophrenic angle. This is the cardiophrenic angle. Then this is the right hemidiaphragm, left hemidiaphragm. After that, look the length fields so that you won't miss anything. This is a point that you can use in your practical aspect of life also, in your clinical practice also. See, if you see here, then look the length fields. You have to see it in a zigzag way so that you won't miss anything. Okay, you have to see that in a zigzag way so that you won't miss anything. Okay, 1 second, I will rub this. Okay. So here, this portion is normal. This portion of lung, upper lobe of lung is normal. But here, you are seeing some crescent like this. Okay, you are seeing some crescent like this. Okay, that is known as the left shield sign. So this means nothing. Left means air and shield means sickle. So there is a sickle shaped air pocket seen between the aortic knuckle and the collapsed lung. So this is the left shield sign, which is seen in left upper lobe collapse. A repeat question. Okay. So in right upper lobe collapse, you will get a sign known as, what is the sign? Golden S sign. Okay. Golden S sign. So this is the take home point. So in right upper lobe collapse, you will get a golden F sign, but in left upper lobe collapse, you will get a left shield sign. Okay. And always you should approach a chest X-ray in this format: A, B, C, D, then length fields in a zigzag way. Now we can move forward. So another very common question that are routinely asked is regarding pulmonary thromboembolism. Okay, so the question they can provide you with an X-ray and they can ask you the questions. So if you gain X-ray, you have to see the air fields, then the cosophrenic angle, cardiophrenic angle, bones, everything. Here in X-ray, you are able to see something evident here. So this hump-like feature is known as the Hampton's hump. This is nothing. This is because of pulmonary embolism, there is a lack of blood flow. So it results in lung infarction. So the infarcted lung is seen as a wedge-shaped opacity that is known as the Hampton's hump. Other important thing is you are able to see a dilated right descending pulmonary artery. So that is known as the enlarged right descending pulmonary artery is known as the Pala sign. Okay, and if you see carefully, you are able to see multiple vascular markings in left upper lobe, whereas this portion of the right lobe is showing reduction in vascular marking. That is known as the regional oligemia. Okay, that is known as the Westermark sign, which is the sign having highest positive predictive value. So in chest X-ray, there are very important signs like Hampton's hump, Westermark sign, Knuckle sign, Pala sign, Chang sign, Fleschner sign. Almost this Fleschner sign, Pala sign, Chang sign, all are dilated pulmonary arteries alone. This Hampton's hump will be the wedge-shaped opacity seen in the lung periphery. And this Westermark sign is the region of regional oligemia because of thrombus. So whenever you are suspecting pulmonary thromboembolism, the next thing that you can do is you can go for an echo, and then the most important investigation, that is CT pulmonary angiogram. Okay, CT pulmonary angiogram. You have to do a CT pulmonary angiogram. So what happens in CT pulmonary angiogram will be, I will show you an image like this. CT, it will be seen like this. Okay, CT will be seen like this. So imagine this is the lung field. This is the vertebral body. I will show you. This will be the main pulmonary artery. This will be the right pulmonary artery. This will be the left pulmonary artery. This will be the ascending aorta. This will be the descending aorta. This is the normal anatomy. So, and the branches will be going. So what you will be seeing is inside this vessel, you will see a thrombus like this. Okay, inside the vessel, you will see a thrombus like this, and this sign is known as the Polo Mint sign. Okay, this sign is known as the Polo Mint sign. So in your exams, the question can come like a 55 or 56-year-old patient with a history of leg fracture or chronic travel or chronic immobilization developed a sudden onset of tachycardia, breathlessness, something like that. And what will be the investigation? The investigation will be CTPA, that is CT pulmonary angiogram. Okay, what you will look? You will look for the non-enhancing thrombus. Sometimes the thrombus can be filling the lumen completely, but that is very rare. Usually it will be seen in the central portion or in the peripheral two-third of the vessel like this, and that is known as the Polo Mint sign. Okay, you have to look for a Polo Mint sign, and you should see the Polo Mint sign. So the investigation will be CT pulmonary angiogram. Another important question that can be asked from this pulmonary thromboembolism will be regarding V by Q scan. That is a nuclear medicine imaging. In V by Q scan, first we will do the ventilation imaging. First we will do V imaging with the help of technetium 99 DMSA or DTPA. Okay, DMSA or DTPA. Then after that, you can do a perfusion scan with the help of technetium 99 microaggregated albumin. Okay, microaggregated albumin. So in pulmonary thromboembolism, we will look for a ventilation perfusion mismatch. Why there is a ventilation perfusion mismatch? Because in pulmonary thromboembolism, what happens is the perfusion, there will be obstruction to the blood vessels by thrombus. So there will be mismatch in perfusion. So there will be ventilation perfusion mismatch. The ventilation will be normal, but the perfusion will not be normal. So there is a ventilation perfusion mismatch. So this is the concept of V by Q scan, that is ventilation perfusion scan, which is done using DMSA and microaggregated albumin. Okay. So I hope that is clear. So there you have to read about the X-ray signs, Fleschner sign, Hampton hump, Westenbach sign, Neckel sign, Pallas sign, Chang sign. Then you have to know about CT pulmonary angiogram and the anatomy of CT pulmonary angiogram. And also remember, if there is a thrombus in the bifurcation of this main pulmonary artery, right pulmonary artery, left pulmonary artery, that is known as the saddle emboli. One initial question in 2019, I guess. So a image of CTPA with a saddle emboli was given, and they were asked to find out the diagnosis. So if there is an embolism at the bifurcation of this major vessel, that is known as a saddle emboli. Okay, so simple concepts. Now coming to syndromes, some syndromes which are routinely asked. The one syndrome is Turcot syndrome. So in Turcot syndrome, this is a case of familial adenomatous polyposis. See, there are multiple filling defects in the barium. So this is a barium enema. This is a barium enema. The barium enema is showing multiple filling defects. So these are polyps. In a case of the Turcot syndrome, by 40 years, usually all these polyps will turn malignant. Okay, that is the concept. And the patients can have a brain tumor, usually the medulloblastoma, mostly medulloblastoma. So you have to know something about medulloblastoma. Medulloblastoma is commonly seen in the fourth ventricle, in the roof of fourth ventricle. Usually arises from the roof of fourth ventricle. Why I am telling this is another tumor is there, which is known as ependymoma. Other important question, which is seen from the floor of fourth ventricle. How to remember? EF. Ependymoma from floor. So you will remember medulloblastoma is from the roof. Okay. So medulloblastoma is from. Also we saw that once I told you an mnemonic of diffusion weighted imaging, I and me. In that, M stands for medulloblastoma. It shows diffusion restriction. Okay, so this is how you would differentiate between medulloblastoma and ependymoma radiologically. It usually arises from the floor of the fourth ventricle. It can show diffusion restriction. Or both these lesions are usually commonly seen in pediatric age group, seen in the region of fourth ventricle. See, this is a medulloblastoma. So I hope this is clear. Okay, this is Turcot syndrome. Now coming to some anatomical variants in PNS. This is a very important anatomical variant. This is known as the anatomical variant. This is known as the onodicel. Okay, onodicel is nothing. It is just the posterior most ethmoid cell. This is the posterior most ethmoid cell. So why it is important? Why they are asking about onodicel in an exam? Because if you see this structure, this is the optic nerve. Okay, and this is the internal carotid artery. So this air cell is seen in close proximity with the optic nerve and internal carotid artery. So if you do first by going here, if you don't know that there is onodicel, and if you poke it and go, you can damage optic nerve or internal carotid artery. That is why it is very important. So you should know the importance of onodicel. Okay, so it is the posterior most ethmoid cell that is seen near the sphenoid sinus. This is the sphenoid sinus. This is the sphenoid sinus. Okay, that is the anatomy. Another important anatomical variant that is in PNS will be paranasal sinuses will be the Haller cells. Haller cells is the infraorbital ethmoid cells. Why Haller cell is important? Because this is the maxillary sinus anatomy. This is the maxillary sinus. This is the orbit. So what happens is secretions from this maxillary sinus will be draining through the osteomeatal unit like this. But whenever there is a onodicel here, whenever there is a large onodicel, this can cause narrowing of this osteomeatal unit. Okay, they can narrow osteomeatal unit. Okay, osteomeatal unit. So the patient can have sinusitis, recurrent sinusitis. So it is very important. That is why in exams they ask you about Haller cells or onodicels usually, other than Agarnase or any other cells. Okay, so I hope that is clear. Now we will see about osteosarcoma. So this will be a classical image. They will give you a classical image. The history will be classical. Usually a child, usually between 18 to 15 to 16 years of age, presenting with pain after trauma or without trauma, they will present you with the same. So there will be lesion usually in the diaphyseal region. But remember, 25% of cases can come in epiphyseal region. There is no clear-cut rule that it will occur only in diaphysis. Around 10 to 25% can come in epiphyseal region only. So there will be classical perpendicular periosteal reaction like this, which is known as the sunburst reaction. That is known as the stun ray or sunburst appearance. Okay, that is the classical periosteal reaction that you will see. And you will be able to see the lifted up periosteum like this. That is known as the Codman triangle. So we will see the Codman triangle. One important thing that you should understand about osteosarcoma is they can send what? they can say calcified METs to lung. These METs can cause spontaneous pneumothorax. Okay, these METs can cause spontaneous pneumothorax. So sometimes if they ask about a patient with this what osteosarcoma developing sudden onset of breathlessness, don't think that as pulmonary embolism. It is not the pulmonary embolism. It is usually spontaneous pneumothorax because of these ossified METs going in and resulting in the spontaneous pneumothorax. So we should be very thorough with osteosarcoma. Another important spotter or this ortho